Okay, so good afternoon. So let's continue with the specific discussion of clinical pharmacy and pharmacotherapeutics too, the pathophysiology of COPD. So before we start with our lecture, let me have our disclaimer. This presentation is for pharmacy educational purposes only. Some slides, presentations will taken from teaching slides of associations, organizations establishing therapeutic guidelines, such as GOLD for COPD. Any brands, proprietary products, devices mentioned in this presentation is not sponsored nor has intentions for commercial purposes. The lecturer is not affiliated to any pharmaceutical company or sponsors, and learners are also encouraged to perform their own assessment, research, and evaluation on the information discussed in this presentation. Further, this lecture is not a substitute to any direct clinical judgment. So, as we recall for the pathophysiology of chronic obstructive pulmonary diseases, we have mentioned 6 factors, which includes chronic inflammatory changes, we have noxious particles and gases, oxidative stress, inflammatory exudates, smoking-related COPD, and vascular changes. So with this, let us discuss the COPD pathogenesis. Basically, we have mentioned that COPD can be attributed to a number of risk factors, but common to them are these two. We have genetic susceptibility, such as we mentioned in our previous discussion, a deficiency in alpha-1 antitrypsin, and then also is environmental insults to the lungs. This can result from long-term smoking, pollution, exposure to pollution. We also mentioned before vaping or e-cigarettes, and of also infections. Now, genetic susceptibility will cause a decrease in the lung's ability to prevent damage to the lung tissue. Further, if there is environmental insults to the lungs, it will cause free radical production in the lungs and also inactivation of lung proteases. We have mentioned before that chronic inflammatory changes lead to destructive changes in chronic airflow limitation. And these two effects are commonly caused by exposure to tobacco smoke. Now, the inhalation of noxious particles and gases activates neutrophils, macrophages, and CD8 plus lymphocytes, which in turn they will release chemical mediators. So these chemical mediators can be the tumor necrosis factor alpha. We have also interleukin 8 and leukotriene B4. Now, inflammatory cells and mediators lead to widespread destructive changes in airways, pulmonary vasculature, and lung parenchyma. Now, oxidative stress was also mentioned before. Now, oxidative stress and imbalance between aggressive and protective defense systems in the lungs, namely your proteases and antiproteases, may also happen. Now, the oxidants generated by cigarette smoke react with and damage proteins and lipids. Thus, they contribute to tissue damage. Oxidants also promote inflammation and exacerbate protease antiprotease imbalance by inhibiting the anti-protease activity. The protective anti-protease alpha-1 antitrypsin, which I mentioned a while ago, it inhibits the protease enzymes, which includes neutrophil elastase. So in the presence of unopposed alpha-1 antitrypsin activity, elastase attacks elastin, a major component of the alveolar walls. Now, hereditary AAT deficiency, which is on the genetic susceptibility side, increases the risk for premature emphysema. In emphysema from cigarette smoking, imbalance is associated with increased protease activity or reduced anti-protease activity. Now, moving forward, Both of these factors, again, will lead to possible increased oxidative stress. They will increase inflammatory cytokines, as I have mentioned, and of course, increase the protease function. So we will be having imbalances between the protease and anti-protease function, all of which will sum up to lung inflammation. Now, lung inflammation can happen in any part of the lungs, but particularly if the lung inflammation is focused on the bronchial tree, then and if injury or continuous injury will be subjected to the bronchial tree, it will lead to infiltration of inflammatory cells. So such will result to airway fibrosis and narrowing. Further, there will be goblet cell proliferation, which will increase mucose production. And likewise, it will also produce death of airway epithelium ciliated cells. Both of these will further contribute to mucose trapping in the airways, and they will serve as nidus for infection or a source of infection. Summing all of this will lead to chronic bronchitis. Now, on the other hand, if the lung inflammation will focus on the lung parenchyma, and as such, if there would be a increased proteolytic destruction in the lung parenchyma, the following will occur. There will be decreased airway elasticity or recoilability. This will lead to trapping of air within the lungs. Next is decrease in structural supports for airway patency, and this will lead to airway narrowing and collapse. And of course, there will be permanent enlargement of the alveoli. So it will lead to hyperinflated lungs, and there will be presence of bulla on the surface of the lungs. When you say bulla or bullae, these are easily erupted air sacs. Now, when we have bronchial tree affected, normally it leads to chronic bronchitis, and if it's the lung parenchyma, it's emphysema, both of which again are classified as chronic obstructive pulmonary diseases. Now, I have to emphasize though that in COPD, we have mentioned that there are smoking related COPD, and usually this results in centrilobular emphysema, that it primarily affects the respiratory bronchioles. The panlobular emphysema is seen in patients with history of AAT deficiency or the alpha-1 antitrypsin deficiency, and then that extends to the alveolar duct and the sacs. While for the vascular changes, normally we can observe thickening of the pulmonary vessels that may lead to endothelial dysfunction of the pulmonary arteries. Later, such vascular changes will lead to structural changes that would increase pulmonary pressures, especially when the patient is undergoing exercise. In cases of severe COPD, secondary pulmonary hypertension leads to right-sided heart failure or what we call specifically cor pulmonale. So again, this is the pathophysiology of COPD. Thank you. And here are the references.